Hey, good morning, class. If you guys could please go ahead and pass up your responses to the initial question, what questions you guys have regarding blood product administration. Please pass those papers forward so we can go over those at the end of class. I want to make sure that we hit on any of these big questions you guys are thinking about throughout this lecture. Awesome, cool. Now that we have them all collected, let's get going. The point of this lecture, guys, is really just to review some things that you should already kind of have gone over in some of your classes. So blood product administration, obviously this is a life-saving task that nurses are tasked with every day in the hospital. And it doesn't come without some risk. So today we're going to go over some of the anatomy, physiology topics to go along with blood product administration, but then we're going to really dive into some transfusion reactions and what your role really is as the nurse administering blood products. Has anyone in the class either seen someone receive some blood products during your clinical rotations and have maybe any sort of input or story to tell on that? Awesome, cool. I'm so excited that you guys have gotten, a couple of you have gotten to see this in your clinical sites, because it is not something that happens all the time at every clinical site that you'll go to, but it is something that you might run into and you should be pretty confident with when you guys get to the bedside. So let's dive into this lecture. So just to review the class objectives today, we're going to review the anatomy of blood components, the different blood types, and kind of go over that just as a refresher. We will talk through some blood transfusion indications that you may see, really focus on the steps of blood product administration, discuss blood product transfusion reactions. So you guys will actually break into groups a little later on and work through the steps for blood product administration, and then we'll have a little bit of a fun activity at the end for you guys to kind of focus in on some of these transfusion reactions that you might see. So let's remember back in your anatomy and physiology class when we talked about what really makes up your blood. So your blood consists of various blood cells, obviously, but they're suspended in plasma, and that plasma makes up 55% of your blood volume, right? And that plasma is what contains electrolytes, albumin, which you guys remember is that protein, fibrinogen, and other clotting factors. All of that is really contained within the plasma. Then your formed elements of blood are your red blood cells, your white blood cells, and your platelets. And those are the things that we always look at when we're measuring like our CBCs to look at lab results. And those are things that you would probably see given to patients when they're low. So let's just review quickly. What do red blood cells do? Yeah, exactly. They transport oxygen and carbon dioxide. So they carry oxygen to the cells, right? Those oxygen molecules attached to those hemoglobin carry oxygen out to your blood cell or your body's cells. And then they also help to get all that carbon dioxide back and carry it all back to your lungs so you can get rid of it. What do white blood cells do? Perfect. Yeah, they are critical in the immune system. And of course, there's a lot of different types of white blood cells. We're not going to go too much into the aspects of your details of that today. But yes, exactly. White blood cells are really important for your immune system. And then lastly, who can tell me about the platelets? What are they really important with? You got it, clotting. Yes, those platelets are the plugs. We need them so that we can clot. So patients that are really low on platelets potentially have some issues with clotting and could have some bleeding problems. So what of these components can we transfuse to patients? Yep, you got it. Pretty much all of them. So it really depends on what's ordered and what the patient needs. Um, Remember that there's a really big push right now for whole blood. So if patients are bleeding, giving them back everything that they already lost through the process of giving whole blood, right? You're getting all the components in one. But whole blood doesn't store very long. So in the hospital setting, a lot of times you'll see components. So we'll be giving a packed red blood cell for patients that have low hemoglobin and hematocrit. Or we will be giving platelets for patients that have low platelets. We might give something called cryoprecipitate, which is a bunch of those clotting factors that are located in your plasma. We could give those if they are low on clotting factors. So lots of different aspects to blood product administration, and we can really tailor it to what the patient needs. Or, like I said, with patients that are really needing blood because they're bleeding, there's a pretty big push right now in our healthcare system to really try to give them whole blood. And you guys might kind of see that more and more in your clinical sites, and then as you guys transition into practice. So to break that down a little bit further, let's look at these different components. When you are asked to administer blood product to a patient, it is really important that you, as the person carrying out that order, understands why the provider ordered it or why the patient needs that blood product. Again, we as nurses are the patient's biggest advocate and the last line of protection. So we have to make sure that we know why we're doing what we're doing to make sure that it's safe. So in addition to that, I guess I could also say that you need to know why so you know what to look for, right? If my patient needs red blood cells because they have low H&H, I need to know that's why I'm giving them. I need to look for a follow-on H&H, right? We need to repeat that level. Or I need to understand if my patient's getting platelets, well, maybe I need to be assessing for because of a clotting issue, I need to be assessing to make sure that they're clotting, looking at my line sites. Is my patient bleeding worse or is it getting better? So understanding the indication can help you in your assessment of your patient and advocate for their needs. So let's look at each one here. Whole blood, as I mentioned, whole blood is ideal for patients in hemorrhagic shock, right? They are bleeding out. We're giving them back in the right quantities what they're losing. Whole blood comes with some other discussions we can have later when we start to talk about blood typing, but whole blood is definitely a way of the future for trauma patients. But it has a very short shelf life, as I mentioned. So once it's taken, it doesn't have as long to sit in a blood bank before it needs to be given to a patient. So what our country does a lot is to break up donated blood into components, like I mentioned. So the first one you'll see here is packed red blood cells, and that's probably, if you've seen blood products given in your clinical sites, it's probably what you may have seen because this is probably the most commonly transfused in our healthcare system. So when PRBCs or packed red blood cells are separated from the whole blood, they have a 35 to 42 day storage, and there's some factors in there, including like what's in the bag to keep those red blood cells from clotting. So there's different chemicals they put in there, and then what temperature is it stored at, and X, Y, and Z. But as these products sit on a shelf, it is important for you to know that like the longer they sit on the shelf, the less effective they are. So if my red blood cells were drawn and separated and I was able to give that packed red blood cell that was drawn 2 days ago to my patient today, oh, well, they might get a full benefit of all those hemoglobin hematocrit that are getting into their system, and they're probably going to get a nice bump in their H&H when I check their blood levels later. Whereas unfortunately, if I give them, they wind up getting blood products that have sat on the shelf for 30 days, they might not get quite as much effect, only because degradation of those cells as they sit. So that's just something for you guys to be aware of and really understand the timing of of how long these products can sit and your administration practices. So we'll talk about that in a little bit. Platelets, as I mentioned earlier, this is for patients with thrombocytopenia. You guys remember thrombocytopenia means low platelet count, and that's seen a lot with patients with clotting disorders. Or it can happen also in trauma patients that are clotting and using up all their clotting factors to clot. If they're only given red blood cells and not given platelets, they're not going to be able to efficiently continue to clot. So something to be aware of. This has the shortest shelf life. So platelets is one that commonly you'll see having a shortage of. I actually worked at a facility where we had a shortage of platelets, and it was really just because they can't keep them on the shelf for more than 5 days. When I say shelf, keep them refrigerated for more than 5 days, they just become ineffective. So just something for you guys to also be aware of. And then the last one on here is fresh frozen plasma. That's another type of blood product we can give, and as it says in the statement, it's plasma. Plasma, again, remember that's that filler that your cells, not filler, but that's the liquid that your cells flow in, and it contains a lot of the electrolytes, and it helps to maintain that osmolality in your patients. So plasma is a great volume replacement. So it also carries a lot of those coagulation factors that we talked about, or clotting factors, excuse me. So it can be good for patients with some coagulation deficiencies or coagulation issues. And it can replace volume loss. So in burn patients who need a lot of volume, sometimes facilities will actually use plasma as that replacement. And again, it has the longest shelf life, so it doesn't degrade as much, and it can sit actually for a year. There's different types of plasma. This specifically is discussing fresh frozen plasma, which is just a really great tool for rural facilities that have less access to blood products. So it's good to also be aware. When giving different types of blood products, it's really important for you guys to understand how blood type can affect what products are given. So something I see confusing students sometimes is that we know, hey, you're you're A positive, so ideally I'm going to give you A positive, right? You want to get a like-to-like thing. And you guys might be pretty familiar with the universal donor and the universal recipient situation of O pos, O neg. But it's really important to understand that those things change, those kind of rules that we think about change depending on what products you're giving. So a lot of the traditional rules we talk about with donor recipient really come into play with RBCs and whole blood. And why is that? Let's dive into that. So do you guys think a patient with an AB blood type can receive plasma from an O blood type donor? Yeah, no. So kind of tricky, right? O negative, that's supposed to be the universal donor, right? That's what we're told. And it is for red blood cells. So when you start to talk about the different components of blood, we really have to go back and remind ourselves of the difference between an antigen and an antibody. So if you guys see on the chart here, antigens, which are those little guys that are all over my red blood cells, they're glycolipid molecules, and they are found on the surface of the red blood cell, and they can trigger an immune response if they're foreign to the body. So the presence of these antigens is really what determines a patient's blood type. So the 4 main blood types are named for the antigen that attaches to their red blood cell, right? So group A has an A antigen, group B has a B antigen, group AB has A and B antigens, and then group O doesn't have any antigens. They are antigen free on their red blood cells. But antibodies are proteins that are found in your plasma, and these antibodies are part of your body's natural defense. They recognize foreign substances such as germs, and they alert your immune system, which then goes and destroys them. The presence of antibodies in the plasma is what can cause severe transfusion reactions. So a patient with AB blood type can receive O red blood cells, but they cannot receive O plasma. So O plasma contains anti-A and anti-B antigens. So I don't want to get too in the weeds on this because there's a lot of caveats, but it is important for you to remember that antigens and antibodies are different. And whatever antigen your patient should potentially have the opposite antibody in their system. So they have A antigens on their red blood cells, which is what their body recognizes, but their body doesn't want B antigens, in there, right? So it creates this anti-B antibodies. So we can talk a little bit more about this on the next slide, and it'll make maybe a little bit more sense, but I just really want you guys to focus, look at this chart and kind of remember it. The difference between antigens and antibodies is really important when we start to talk about component blood therapies. And it is important for you guys to know this because, like I said, when you guys are the ones checking that blood product and administering it to a patient, you want to be confident that you understand why that patient's receiving that blood product. So on the next slide, I will show you. First, I want to pause. Does anyone have any questions on this? Okay. Nope. So let me show you this next diagram. So this is a compatibility chart, and I think this helps to kind of make sense of what I just talked about. So if your patient is O negative or O positive, we can talk about the negatives and positives later, but the O patient, that is their which one? Right, their antigen. They don't have any antigens. So they can receive red cells from all the different blood types, O, A, B, and AB. They can give plasma only to other O's though, right? Because they have the antibodies to A and B. Okay, let's go down, we'll jump down to the bottom now. So your AB patients have both A and B antigens on their red blood cells. But that means that they don't have anti-B or B or A antibodies in their plasma. So therefore, they can give plasma to anyone, but they can only receive red blood cells from AB patients. Okay, so now that we've done a quick review on the anatomy and physiology and really understanding why your patient's getting what they're getting, the rest of this lecture is really going to focus on the skill and the steps involved in blood product administration. So I cannot hit home hard enough to you guys how important it is that we follow these steps carefully, and no matter where you guys wind up working, if you are giving blood products, I guarantee they should have a standardized protocol of steps that you'll follow. And every facility has slight variances, so the steps we're going to go through today are kind of a generalization of what you should do. Of course, wherever you work, and I challenge you in your clinical sites to ask, to see the protocols, to kind of get familiar with them, but wherever you work, they will more than likely or should have a protocol for you to follow. So again, these steps are kind of an overview that you should see similarities anywhere that you work. So the beginning of blood product administration is going to start with the preparation. You're going to, of course, verify that the order and the indication. So if you're using electronic health record or if it's paper orders, you're going to verify what the provider orders. They want 1 unit of RBCs, or do they want 2 units of platelets? Whatever the order is, make sure you understand it and it's accurate, and you understand why. I actually not long ago had an order on a patient for an electronic order. So on the computer it showed up, says transfuse 2 units of PRBC's stat. And it said in the order, it said for suspected GI bleed. Okay. The patient that I was taking care of had no signs or symptoms of a GI bleed. So I was a little bit confused. They even had a great H&H. So what did I do? I called the provider and I said, hey, I noticed that you ordered this, but this patient seems that that's not an appropriate indication for them. Or can you explain to me, why we're doing this, just so I understand? And the provider said, oh my goodness, I am so sorry. I put that order in on the wrong patient. So that's something, you catch it because you're questioning the indications and you want to understand the why. So first step is that. Second step is that you will verify blood type and cross matches done. So if you are in a facility, you are going to want to make sure that the patient has their blood type on file with the lab. And this process can be slightly different at different institutions. Most places I've worked require 2 samples on file, 2 samples that are taken at 2 separate times. Some places will require this to even be signed and verified by 2 people that it was done correctly, just because giving the wrong blood product to the wrong blood type to the wrong patient could be so detrimental. So this is something you have to be assured you see in the chart. And the longer you guys are in taking care of patients, the more you'll learn to kind of recognize when you should be looking for that anyway. So do I have a patient going to surgery? Do I have a patient that's high risk of bleeding? I'm always looking in their chart to see if they have been typed and crossed, just to have one on record, because the delay in that process could really be life or death if a patient starts bleeding. So something you might implement into your practice is just if you think the patient could need blood products for some reason, check their chart and see if they've had a type and cross or a type and screen done during their stay. And then the cross match part is done when they actually match that patient's blood product or blood type to whatever unit they're going to get. So the type and screen would be done to screen your patient, and then a cross match is done when you're ready to give blood. Next, you're going to obtain a baseline vital sign. This might seem kind of obvious, but obviously we want to start with what their vitals look like before we give anything. And we'll talk a little bit more why that's important in a bit. What do you guys think is included in that baseline vital signs? What vital signs do we need to take? All of them, right? Yeah. So we want to make sure we get a heart rate, a blood pressure, a pulse ox, and a temperature. A temperature is a big one that we forget about, and a respiratory rate. But temperature will be very important when you start to look at the different types of reactions you could see with blood product administration. So next, we're going to assess the respiratory and cardiovascular systems. So again, just like with our baseline vitals, we want to get a good baseline of our patient. So we should do a good assessment. The respiratory system and the cardiovascular system are 2 things that we could see the effects of a transfusion reaction in. So we should be making sure we know what they look like to look for changes. Using the 2-person verification process, we will check the blood product and verify client identity. So this 2-person verification process is pretty standard across the board at almost everywhere you'll work. And this is really a patient safety thing to ensure that 2 people are carefully slowing down and looking at the blood products being given to the patient to avoid any critical errors. So let's talk about that 2-person verification process. When you go pick up blood from the blood bank and when you are at the patient's bedside to give blood, you and another, typically it's another RN, at most facilities they require it to be an RN, but you and the other nurse will ensure both individuals are qualified per whatever policy. Then you guys will, one of you stay at the bedside with the client for the first 15 minutes, so that's an important thing to note. You're going to make sure that the blood that you pick up is what the provider ordered. So you're going to look at the blood product versus the provider's order. You're going to verify you have the right patient with that blood product. So name, date of birth, and a lot of places will make this two ways. So the patient's wristband, you can ask the patient, maybe their chart, the order record, something like that. You will verify the blood bag identification number. So every unit of blood drawn within the United States has some sort of identification number. A lot of times it starts with a W and then a long bunch of numbers. And you will see when you're in the hospital, if you guys are watching nurses do this, we read that number and then someone reads it back. So that's what the dual verification process is everything I say, they're going to listen and read, and then when I'm done, they will read all these things back. So that way we have no confusion. Again, verifying the blood type, the RH compatibility, which we didn't talk too much about today, right? But that is that positive or negative after the blood typing. And that comes really into play when we start to talk about women receiving blood products that are of childbearing age, because if you receive a product, if you're A positive and you receive A negative, that's fine. If you're A negative and you receive A positive, it's really not often going to cause a big issue until potentially that RH compatibility issue comes into play. Like if baby, it doesn't have or that RH, that negative or that positive on their blood type, and it mixes with mom's and it mixes with mom's blood. So you guys might remember learning about ROGAM. You guys remember that? Maybe. If not, maybe you guys take a note, write that down, and review it. It's kind of out of the scope for today, but I want you guys to be familiar with that process, that fact of giving blood as well. Sorry, digressing. So then we're going to verify that the blood has not expired. That's obviously very important. And then signing the transfusion form or the electronic record. So you'll do this readback process at the blood bank typically with the lab personnel, and then you'll also do it at the bedside with another qualified personnel, nurse. All right, now you have verified and you are all good to go. It is time to start. So hand hygiene, we do hand hygiene with everything, right? That's important. We want to make sure that the patient stays nice and healthy and doesn't get an infection. We're going to put on clean gloves. Then you're going to prime your administration tubing with normal saline. So you guys are going to get some practice with this after we're done chatting here. If you're not familiar with blood product or blood tubing, there is a filter in it. In the drip chamber, typically that's where you'll see the filter, and then it has two spikes. So you'll have one line that goes to the client and to the patient, and two spikes. One of those spikes is going to go to a saline bag to keep that line primed, and then the other spike will go to your actual blood products. So first we will prime the line, and traditionally you will hear prime the line with normal saline. There's a lot of reasons for this. Normal saline doesn't have has a low amount of calcium, and calcium can supposedly affect the clotting. It's part of your clotting cascade, so it could affect the clotting in the blood product. So normal saline is the only fluid that you'll ever see to hang with blood products. So normal saline. Prime the line, spike the blood product after you primed your line. So you prime your line, clamp all of it, and then you will spike your blood product. Then you can place the administration tubing into an infusion pump, or if you're going to just rehang it, whatever the facility does. Infusion pumps are great because they can help you to control the rate that you're going to give this blood to a patient, which is really important when we are talking about looking for reactions, right? If I dump it all in there really fast, I might not have as much time to look for a reaction. There are times we have to do that for trauma patients, but normally in most settings when we're giving blood, we have a nice controlled rate that we'll start at. Again, the rates are going to be part of your hospital policy, but normally it starts slow and then you slowly increase it. Just like with any time you're accessing the line, you'll scrub with an alcohol pad on their IV site. You'll flush the line, make sure it's good. Then you're going to attach the tubing to your patient, and they say here to label the tubing near the client for quick identification. That's always a good practice to get into, and a safe practice to get into. If your patient has a lot of lines going on, it's nice to be able to look at it and know what it is. Excuse me. Next, like I mentioned, begin low and slow. So you're going to begin your infusion at a low rate, somewhere between 30 to 50 mLs or to your hospital policy. And then you'll remain at the bedside for the first 15 minutes. So this is something I have never seen changed from every hospital I've worked at. 15 minutes with the patient is must. Why do you guys think that is so important? Yeah, so the first 15 minutes is when, yeah, you guys see it on the slide, huh? So the first 15 minutes is the most common time to see a transfusion reaction. After the first 15 minutes, you'll perform respiratory and cardiovascular assessments and recheck vital signs, and monitor them per whatever the protocol is for your facility. A lot of places will do you'll do 15-minute vitals, then you'll do another 15-minute vitals, and then you'll go to 30, and then you can go to an hour. It really depends on your facility. I've seen a couple different ways that they do it, but frequent vital signs at first, and then it can space out. And you can also increase at whatever the prescribed rate per your protocol. But typically, after the first 15, if they're not having reaction and they're tolerating it well, you can double that rate and then slowly go up. If a transfusion reaction or the line infiltrates, something happens, stop the infusion and notify the provider. Depending on the type of reaction, changes a little bit how you respond and what you do with your patient. So we will talk pretty in depth about transfusion reactions in a bit after you guys kind of go through these steps together. So I want you, as you guys are going through these steps together, to really go slowly and think through the importance of each step. Okay, so it's easy to check a box and do a step, but I want you to really understand why you guys are doing these steps. Why are you checking vitals? What are you looking for in those vitals? So as you guys work in your pairs, one of you will be the client, one will be the patient receiving the blood product, and then one will be going through the steps, and then you guys can switch and practice. As you guys are going through it, challenge each other. Ask your partner, oh, why are you doing that? Just like a patient would. A patient would say, well, why am I getting this blood? Oh, why are you guys verifying the blood? Why do you guys keep saying my name? Why do you keep asking me my name? So, challenge your partner, and it may seem silly, but it's a great opportunity for you guys to practice communicating with patients and educating patients on blood product administration. All right, so let's just make sure everyone's understanding what you guys are about to do. So you should be in your groups of 2 already. If not, please identify a partner. Everyone get with a partner. Good. So one of you will be the nurse to start, and one will be the patient, and then you will switch up. The patients come down here and grab your checklists. You guys can grab an extra checklist for your partners, but don't show your partner your scenario. I want them to kind of work through it a little bit. And then if you are in the role of the nurse to start, you can go to the back of the class and grab your supplies from the supply buckets. So you should be getting some IV tubing, blood tubing. There are fake blood bags and normal saline bags for you guys to practice spiking and priming your lines and spiking your blood. Once you guys have collected your stuff, find a corner of the room to work in. It is going to be a little bit loud in here, so try to remember to keep the volume down so everyone can hear what they're doing and work through the process slowly. I challenge you guys, if you're playing the role of the patient, to kind of play dumb and really challenge your partner to be better. So ask them to explain why they're doing what they're doing, just like we would in real life. We educate our patients as we're doing different things. So if I'm giving a patient a blood product, there is so much education involved. You are going over why they're getting the blood product, what they need to let you know they're feeling to be looking for reactions, and why you are checking their blood pressure every 5 minutes, and why you have another nurse in there asking them their name. All these little parts that go into blood product administration are part of the checklist, and they are safety things, and we understand why as nurses, but it's really important that we educate our patients so they're not scared. So as you're going through the activity, I want you guys to kind of challenge each other and ask those questions so you get practice teaching and thinking through why you're doing what you're doing. In about 25 minutes, we'll regroup and we'll discuss some of the reactions that maybe you guys have seen. All right. All right, guys, let's regroup. So we're going to go over the different signs and symptoms that you guys probably experienced after you went through your checklist and started giving blood product to your patient. Hopefully, these were ringing some bells from your pre-class reading, these reactions that you saw. So let's dive in. So the first patient we'll talk about, you guys might have started to see them at that 15-minute vital sign check. They might have had a temp increase, a blood pressure might have gone down a little bit, started feeling anxious, and maybe really within the first 5 minutes, maybe they started to complain of back pain and just general discomfort. Who has that one? And what do you guys think the type of reaction was? Yeah, acute hemolytic transfusion reaction. So, an acute hemolytic transfusion reaction, you have that card. Can you guys read to me a little bit about that? What does it say causes it? And the patient would read, or the student would read, antibodies in the recipient's plasma attached to antigens on the transfused RBCs, causing RBC destruction, usually due to ABO incompatibility. Incompatibility due to improperly labeled blood sample, improper identification of donor unit, and/or misidentification of the patient. Hopefully you guys didn't have that, right? You went through your checklist and didn't misidentify. That doesn't mean there's not another place that error could have occurred. Potentially in the lab, they mislabeled it before you guys ever got to the situation. So it could happen, or potentially the patient was typed and screened wrong. These things happen. Blood tubes can get switched around. That's why we have so many checks to try and ensure it doesn't happen. But the acute hemolytic transfusion reaction, sometimes you'll see people refer to it as AHTR. And this type of reaction is really, really bad. This is probably one of the worst things that can happen. Their body's just going to start to try to attack those red blood cells circulating their system, and it is not a good time. Typically, this happens, like I said, within that first 5 minutes. This is going to be a quick symptom onset. Back pain is one that it's kind of a unique one for you to be looking for. I tell patients when I'm teaching them prior to administering products, I always teach them, hey, if you start to feel some back pain that's new, please let me know right away. Fever, chills, that kind of thing might be seen with some other stuff, so that's good to pay attention to, but it is seen in other types of reactions. Chest tightness, anxiety, again, also kind of seen. So it's good to pay attention, really close attention to your patients in those first 5 to 10 minutes to really be able to catch these. So what do you guys do? It says on this sheet as well, so if you guys want to read it out loud, you can, but let's talk about what do you do if you suspect your patient's having an acute hemolytic transfusion reaction. Exactly. So you're going to stop the transfusion immediately, notify your provider. You can keep their line open with some saline because you don't want that line to go bad. You're going to check your vital signs frequently, including urine output, because this can affect their kidneys and cause some damage. You want to be aware that an ABO incompatibility that causes this really can be detrimental to patients, and they might decompensate rapidly. So if you're in a facility and maybe you're not on a critical care floor, making sure that you notify the RRT of this patient so that they're aware and they can move in quickly if needed. Obviously, don't restart that transfusion and let the transfusion services know. So blood bank will want to know of any reaction. So you'll see that with almost all of these, but really important to make sure that they know. Alrighty, let's move on. So, who had the patient that developed a fever at their 15-minute temp mark and maybe complained of a headache? Good. And what type of reaction do you think? Exactly. This is called a febrile non-hemolytic transfusion reaction, and sometimes this one is abbreviated FNTR. So a febrile non-hemolytic transfusion reaction, you're going to see this when your patient kind of passively gets cytokines or some sort of antibodies from that patient that they're not used to. And this is aside from the blood typing and blood antigens or antibodies. This is the patient is receiving some sort of cytokine that's in that patient's blood that wasn't eradicated during the collection process. So you'll sometimes see at the hospital blood products say leukocyte reduced, or that's probably a common one that you'll see is the leukocyte reduced. But there's different things they can do to blood products to limit this from happening and get rid of any antibodies that could be in there that could cause this, or any cytokines that could be in there. But it is still something that could happen fairly frequently. And if it does, your patient probably is going to get that febrile reaction, but they shouldn't have any of the other like dramatic things like the hypotension, etc. They can obviously your temperature changes. If you're giving them warmed blood products, which a lot of times we are, it might change. So it is important to know your policy. Every facility is a little bit different, but typically if it's a change of 1 to 2 degrees Celsius from pre-transfusion value, then it is more significant. But again, that's really hospitals sometimes will change that. So just be aware of whatever your facility is. But that's why we do check that temperature in your patients frequently to look for that change from baseline. We want to make sure, what do we do? Sorry, let's talk about what did you guys decide to do when your patient started to exhibit that? Perfect, you guys did it right. So stop your transfusion again, just like with other things. Notify your provider. You want to make sure you rule out other causes of fever, because a lot of things can cause fever, right? Infection, a pulmonary embolism can cause fever. Your patient could just straight up be too hot. So there's lots of things that can cause fever. We want to rule out others. And then manage the symptoms. A lot of times providers will order Tylenol or some sort of antihistamine, because this fever reaction is because of their histamine reaction. So they might give them some sort of like a Benadryl or something. And then let transfusion services or blood bank know that this reaction happened, so that they can test that blood and see, what kind of antibodies. I am having a brain fart. What type of antibodies are in there that could be causing this? So, good. Alrighty, guys. Should you could you restart that blood? Yeah, no, probably not. You will, sometimes this might get confused with another thing that we'll talk about in a bit, and sometimes providers will treat and restart, but typically if their fever really jumps this high and we think it's a febrile non-hemolytic transfusion reaction, we're going to stop that. We're going to stop that blood product. All right. Who had a patient that started itching on their arms and complaining of feeling itchy, and not long after the transfusion started? Good, yay, perfect. So you guys had the mild allergic reaction. So mild is important to note because a lot of patients can have reactions from blood products that it's not going to be severe enough to kind of outweigh the benefit of the product. So they might get a little bit of itching. The edema on their lips or tongue is not a great sign, but they might get some itching that makes it mild. I would argue, I guess this slide probably could be altered a little bit. The respiratory distress is not mild, so that really should be moved down. But if your patient just has some hives and itching, what did you guys decide to do? Good. Stop it. I like it. So you stopped the transfusion, notified your provider, and anticipated some sort of antihistamine. So a lot of times we will wind up giving Tylenol and Benadryl to these patients, and sometimes we'll restart it at a slow rate and see if they get better with that antihistamine on board. If they really need that product. So letting the provider know and seeing if we can give some sort of transfusion, medication. So Benadryl and Tylenol are the most common, but there's also sometimes we'll get steroids or something. But ask your provider for those things. So good. You can still let transfusion services know. All of these, when you guys are, if you're using like an electronic health record or even a form, it will ask you when you're done with blood or when you stop blood if you're suspecting a reaction, because they want to know that and they want that blood product back to test it. So, that's the only way we can get better and make sure we prevent harm. So all of these, even if it's a mild reaction, they'll want to know about it. All right. Who had the patient who, within the first minute of starting the blood, complained of feeling hot, itchy, they couldn't breathe, they were short of breath and wheezing? Who had that fun one? Yes. And what kind of reaction were you guys having? Perfect. Anaphylaxis. So this is the much more severe allergic reaction that we need to worry about. And this is because the IgG antibodies to IgA or complement C4 haptoglobin. So those are a lot of big words, right? But there is some sort of IgG antibody your patient is getting in that blood product that they are reacting to, and they can go into that anaphylactic reaction when exposed to that product. So, excuse me, just like with any other anaphylaxis, what's the biggest concern we have? Airway, absolutely, airway. We want to make sure that the patient doesn't lose their airway. So we're going to stop the blood products just like with all the other reactions. Let the doc know, keep that IV line open. We're going to need it. Frequent vital sign checking, but big thing for these guys is to maintain oxygenation. Make sure that they maintain their airway, and that they, if they become hypotensive, that we respond appropriately. So just like with any other type of major reaction, epinephrine typically is going to be the treatment of choice. So they may require epinephrine if it gets that severe, and they may need to go to an ICU for more definitive airway management. Do not restart the transfusion for these patients. Benadryl's not going to fix anaphylaxis. So we want to make sure that we stop this. This is pretty rare, and again, really would occur quickly in these patients within the first minute or so. So important to be aware of, but don't be scared. Very, very rare. But still be prepared if you were to get these symptoms right away. Maintain that patient's airway, get them epinephrine on board, let the providers know. Obviously, please, please, please stop the blood. Really important. All right. That one was fun. All right, guys. Let's talk about who had the patient where your blood pressure decreased at their first vital sign check, your heart rate increased, maybe they got a temp, their respiratory rate increased, and they just couldn't breathe. But it wasn't sudden. It happened kind of over a little bit of, that first 15 minutes, right? Good. And what kind of reaction do you guys think that was? Yeah, exactly. Trolley. So transfusion-related acute lung injury. Again, not super common, but it does happen. I have actually seen this happen. And why does this happen? Good. And the student could read off of the card. So it says reaction caused by white blood cell antibodies or biologic response modifiers in the transfused unit reacting with the patient's white blood cells, leading to a release of destructive cytokines that give rise to pulmonary endothelial damage, capillary leak, and pulmonary edema. I will add, so trolley, they don't always know why some patients get trolley and some don't. It has decreased since we've been making sure that, obviously it's been decreased since we give blood products at a slower rate. And actually there is some indication that if we give it warmed instead of cold, that somehow patients develop Charlie less frequently. I don't know if that's, I don't have all the science to back that up in front of me, so you guys can look more into that. But Trolley is something you should be aware of and look for in your patients. So Trolley can happen acutely, but it can also happen up to 48 hours post transfusion. So that is really important for you guys to know that it could happen within the first couple hours, or it could happen later and they develop these signs and symptoms. So be aware that respiratory distress, tachycardia, fever, they really start to look septic. So if you guys have seen a septic patient, they almost start to look like that. And it's their body's having this reaction to the blood, and it's kind of causing them to go into this. They can go all the way into ARDS. Do you guys remember learning about ARDS? Acute respiratory distress syndrome, and their lungs become very difficult to ventilate, and it's a not a good situation. All right, next and last, who had the patient that was pretty stable, but their second check, they became actually hypertensive, so a little bit different than the rest of them. Their heart rate went up, their respiratory rate went up, and their SpO2 decreased. Yeah, perfect. And then you can see some more signs and symptoms here we didn't talk about, but they might have rales when you listen to them, a dry cough, wheezing, hypertension, headache, and distended neck veins. So why do you guys think the distended neck veins is a symptom? Yeah, they're overloaded because they have transfusion-associated circulatory overload. This is the fun one, TACO. Not fun for the patients, but it is fun to say. So TACO is something we should always be aware of if we are giving blood products to a patient, especially our patients with cardiac underlying issues or renal underlying issues, our older patients, or patients that maybe we're giving blood products to quite quickly. Because remember, guys, that it's volume, right? Blood is volume. So if we already have a pretty full tank and we add more volume to it, we do risk overloading the patient. Providers and nurses, we should be aware of why the patient's getting the blood product and aware of their volume status so that we can kind of play risk benefit with it. Is this going to be too much volume and cause problems? Even though they need those little hemoglobin molecules. So just be aware. Giving patients blood products too rapidly can really exacerbate this. So I have seen a patient go into TACO. It was a trauma patient. They needed the blood. They were bleeding, so I had to give it to them fast, and we had blood going through a rapid transfuser. Unfortunately, they also had cardiogenic shock, so their heart wasn't pumping, and they wound up just having all this volume that went in too quickly, and their heart couldn't handle it. So just be aware that TACO it can happen and kind of what things to look for, that overload. Good. Are there any questions with this content that we've gone over, these reactions? Hopefully you guys did the pre-class reading and reviewed so that these weren't the first time you're seeing these reactions. All right. If we don't have any questions about that, please make sure you guys clean up all your spaces. We will, last thing we'll do is just, I'm going to review some of the questions you guys wrote down at the beginning of class, and we'll go through. I'm going to see if any of these were things we didn't answer, or please, if you guys have any questions that develop throughout class, please let me know, so we can work through them. I want to make sure you don't leave here with any looming questions. Please write them down if you have them. All right.